You ready, Krishna?
Yes, sir. Good morning, sir.
Good morning, sir. Morning. Okay, we can start.
Yes. Shall I start, sir?
Yes, please.
Here is a 68-year-old female, a resident of Alwar, who is a housewife, presented with chief complaints of mass in the right upper quadrant since 1 year and pain abdomen since 15 days. Coming to history of presenting illness, patient noticed the mass in right upper quadrant 1 year back, insidious in onset, initially of size 4 into 4 centimeter, which has gradually progressed to a current size of 7 into 7 centimeter. Not associated with pain abdomen initially, there is no sudden increase in size of swelling. Patient noticed pain in the abdomen since 15 days or right upper quadrant, insidious in onset, dull aching type of pain, mild in intensity, intermittent, no radiation of pain, not associated with food intake or change in posture. Pain relieves by itself only once in the past 15 days patient has taken oral analgesia. No history of nausea or vomiting, no history of fever, no history of jaundice, melena, no history of trauma or contact with pet, no urinary complaints, no history of abdominal distension. There is no history of early satiety, no history of loss of weight or loss of appetite, no history of any other swelling elsewhere in the body. Coming to past history, no history
Online class.
history of pain abdomen in the past, no history of diabetes mellitus, hypertension, tuberculosis, or asthma. Personal history, patient consumes vegetarian diet, sleep is regular, appetite is good, regular bowel and bladder habits, no history of alcohol consumption or smoking. Coming to summary, 68-year-old female with no comorbidities with gradually progressing mass in right upper quadrant since 1 year, with the recent development of mild dull aching intermittent type of pain since 15 days. No associated fever, jaundice, loss of weight or loss of appetite.
Okay, go back to your first slide, please. Yeah. Conventionally, age is always written in numbers. You have written 68. I think you followed the manuscript guidelines where it is said that if the first word is a number, you don't write number.
Yes, sir.
Partly, but in case presentation and in clinical notes, age is always written in numbers. Okay. Next.
Right.
So when you have these two presenting complaints, what do you make out?
It is a very vague history, sir. Complaint. Usually, it will be some benign pathology.
So you're right. If we don't consider the last 15 days, for 1 year, the patient has had a largely asymptomatic mass, isn't it?
Yes, sir.
And even the pain now, as you described, is only mild, dull, diffuse, on and off, not requiring
more of a discomfort rather than
more like a discomfort. So basically, it is an asymptomatic lump in the abdomen, which is gradually, slowly, progressively increasing in size for 1 year.
Yes, sir.
So you are right that this history suggests a benign disease rather than a malignant pathology. Next slide. Why did you ask for a sudden increase in size? Why would a swelling increase suddenly in size?
Patient gave history of recent development of pain. Any hemorrhage in the existing swelling can have sudden increase in size and can be associated with pain.
Yes. So typically seen in
adenomas with hemorrhage or any cystic lesion.
Which adenoma you are referring to?
Hepatic adenoma can have.
Adenoma is known more for its rupture and intraperitoneal bleed. That also will give rise to pain, but it will not give rise to sudden increase in size of swelling, which is the lump in the abdomen, which is typically history that there is a sudden increase in size and there is severe pain because of intra-lesional bleed.
Hepatic cyst or
Okay. Hepatic cyst bleed is more common, or some other cyst bleed is more common related to pancreas?
pseudocyst bleed is more common.
Pseudocyst. So pseudocyst, especially on the background of chronic pancreatitis, where there may be an arterial complication in the form of a pseudoaneurysm, that probably will be the commonest situation where the patient can give this typical history that there is a sudden increase in size of a swelling which was either static or slowly increasing in size, and there is severe associated pain. So that is the typical history of a intralesional and usually intracystic bleed.
Yes.
Okay, because the other condition which can give rise to pain is a tumor necrosis, but that doesn't result in a sudden increase in size. That is a slow over a period of time process. Okay, next. So what is your interpretation of the pain here? What do you think? Is the pain related to swelling? What is it? How do you connect the lump with the pain?
It can be related to swelling, sir. Gradual increase in size. Once the swelling size increases, there can be some compressive symptoms or else stretching of the lesion and causing pain. So it can be associated with the swelling as such. Right now, I'll associate the pain to swelling only, sir.
Okay, next. So when you have a patient who has a lump in the right upper abdomen, which negative history is most important?
Jaundice is most important, sir.
So that should come first,
Okay.
isn't it? So even the negative history should be mentioned in order of importance. For an MBBS or an MS student, it is all right that he starts from esophagus, stomach, duodenum, liver, gallbladder, whatever. But at your level, I expect that even the negative history you critically analyze and tell us the most important negative history first, and then the routine negative history. So jaundice and fever probably are most important here. Suppose it was a patient who has epigastric pain, then obviously nausea and vomiting is more important. Suppose you are thinking of a CA stomach or a CA colon, then history of GI bleed becomes more important. So the sequence in which you mentioned your negative history also indirectly tells the examiner what you are thinking and what is going on in your mind. Okay?
Yes.
Next. Actually, go back, sorry. If I do a very kind of critical analysis, history of contact with pet probably should go to personal history.
Okay, sir.
Not okay. It becomes part of personal history. Next. So early satiety you have mentioned here, and nausea and vomiting you had mentioned there. Are these related to two different organs?
No, sir. It is related to
They are
same.
part of the same story. So when you have either a lesion in the stomach which is causing or going to cause gastric outlet obstruction, or you have a lesion which is compressing the stomach from outside, or you have a malignancy which is widespread, which is causing what is known as malignant gastroparesis, the sequence of symptoms starts from a feeling of postprandial fullness, early satiety, nausea, and then frank vomiting. So they are part of the same story. So they all should come under one in one sentence, that there is no history of postprandial fullness, early satiety, nausea, and vomiting. The moment you mention this, I know that you are thinking of gastric outlet obstruction.
Yes. Okay, sir.
Okay.
Okay. Correct.
Why did you ask about no history of any other swelling anywhere in the body? What were you thinking?
One of my differential diagnosis is hydatid cyst, sir. So it can present with multiple swellings in the abdomen. So I asked for.
But you are saying anywhere else in the body?
Rarely it can present. Mainly, I wanted to ask for abdomen. It can even present with swellings in the other parts of body also, if hydrated
But
rarely.
will it be palpable?
Um, no, no, sir.
Except maybe a bone,
Um,
except. Yeah. So you could have said that she hasn't palpated or she's not aware of any other lump in the abdomen. That is all right. And so which condition, not common, I wouldn't make a clinical diagnosis of that, which the patient can have an abdominal lump and can have some other swellings or lumps in the body.
lymphomas can have
Yeah.
abdominal swelling, and
So patient can have lymph nodes everywhere, which she doesn't know are lymph nodes. She just says that they are lumps, isn't it?
yes,
And any soft tissue tumor, which is known for its multiplicity.
a lipoma.
Lipoma can be, yes, multiple, more common than lipoma, which is multiple. A neurofibroma.
Yes.
So
Yeah.
you can have a retroperitoneal tumor and patient can have multiple lumps all over the body in some of these conditions. But as I said, that would be the last clinical diagnosis, which we will make only after examination. Yeah. Okay. Next. So the history of contact with pets comes here. You said that no history of contact with pet. What do you mean by that? All of us mention that in the history, but what is the connotation?
Usually, uh, the hydatid cyst is usually acquired by dogs, through the dogs. So that is one of the most common mode of acquiring hydatid cyst.
But you said no history of contact with pet. Dog is not the only pet which people keep. I can
Yeah,
have a cat pet.
rearing of sheep and other things are also common in our part of the country. So that is also one of the modes of acquiring hydatid cyst.
Sheep is the
Intermediate secondary host, sir.
sheep. I don't think sheep is sheep the secondary host. Sheep is the primary.
Dog is the primary.
Dog is the intermediate. No. Anyway, check on that. I am also not
I'll
sure.
check.
Yeah. Okay. So, if a patient doesn't have a dog as a pet, he or she cannot have hydrated disease?
No, sir. They can have. That is the most common mode of acquiring. Even
Yeah.
contaminated vegetables where they use manures which are contaminated by
Yes.
feces can also acquire hydatid cyst.
It's not necessary that you have to have a pet to have hydrated disease. Okay. Next. So, what is your analysis of the history? You said you think it is a benign disease.
Yes,
Can
sir.
you elaborate more?
Patient is having the mass since past 1 year, largely asymptomatic, with recent development of pain, sir. So more, I'll be thinking in terms of benign disease only, and my first differential diagnosis will be hydatid cyst of the liver, sir. I am keeping other things in mind also, since it is a vague history. It can be rarely hemangioma of liver, or else retroperitoneal tumor is also one of the differential diagnosis. I'm keeping pseudocyst of pancreas also in mind, sir, as of now.
So, when I asked you what is your analysis, instead of repeating, because you have already said that 68-year-old 1 year lump, you don't have to say that. You come straight to the answer. Okay. So, why do you think, or why have you placed? Dr. Kotecha from Tanzania says that dog is a definitive host in the cycle of echinococcus. Thank you. Thank you very much. So, why do you think of hydatid as the first diagnosis rather than?
Largely asymptomatic mass, sir, which has started producing symptoms right now. So
That we have accepted, but hemangioma and retroperitoneal tumor also behave the same way. So why have you placed hydatid first? Why not retroperitoneal tumor first?
hydatid cysts are more common than these pathologies.
Good.
So
So whenever you have multiple possibilities in the clinical discussion, you always put the commonest first. In theory answer, you organize them in whichever way you want, but in practical exam and clinical exam, you always mention the common things first. So is hydatid more common or is the hemangioma more common?
hemangiomas are
If you
more
do,
common, sir.
yes.
But
So why not hemangioma?
symptomatic hemangiomas are rare.
Symptomatic and palpable. Here, more important is palpable.
Yes,
She
sir.
has palpated. So, if a hemangioma is palpable by the patient, it has to be a massive hemangioma, very large hemangioma. So, that is less common. Otherwise, hemangioma is much more common than hydatid. If you do ultrasound of 100 people, you will find hemangioma, but you may not find a hydatid cyst. But most of them are small, they are deep seated, they are asymptomatic. They are incidental findings on investigation, on imaging.
Yes.
So, a palpable hemangioma is definitely less common than a palpable hydatid cyst. Okay?
Yes,
Yeah.
sir.
Retroperitoneal tumor. Why do you say retroperitoneal tumor?
Because of the locations, right upper quadrant, right, and largely asymptomatic and age of the patient.
So location is not the point in favor of retroperitoneal. Retroperitoneal tumor can occur anywhere in the abdomen. It is large asymptomatic. So you should remember, if you have a largely asymptomatic lump in the abdomen, the possibilities are, as you have rightly mentioned, hydatid. I would, in a female patient, I would also add ovarian cyst, but that would be usually in the lower abdomen. It could be a retroperitoneal tumor. These are the common large but largely asymptomatic lumps in the abdomen. And why have you placed pseudocyst at the bottom of the list?
Because pseudocyst usually will have symptoms, sir. It can be asymptomatic, but symptoms of acute or chronic pancreatitis will be there, or else any inciting history of trauma, it can be there. That's
So
why
it is not the cyst which you should say is symptomatic. It is that pseudocyst usually occurs in the background of symptoms or an episode of acute pancreatitis or symptoms of chronic pancreatitis or with history of abdominal trauma. In the absence of any of these three, it is very difficult to make a diagnosis of pseudocyst of pancreas. So suppose you have a lump in the epigastrium or in the left hypochondrium and patient doesn't give history of acute pancreatitis, chronic pancreatitis or abdominal trauma, then it would be very difficult to make a diagnosis of pseudocyst. Then you start thinking of other cystic lesions.
Yes.
In fact, that would be one situation where you have to entertain the possibility of a cystic neoplasm of the pancreas. And recently, my colleague Dr. Vinay Mahala operated on a case where it was a splenic cyst in that region. Okay. It could be a large retroperitoneal cyst. It could be a large renal cyst or a hydronephrosis, isn't it?
Yes, sir. Yes, sir.
So I agree with you that pseudocyst you will keep as the last possibility in this list because there is no history of acute pancreatitis, chronic pancreatitis, or abdominal trauma. Did you mention about no history of abdominal trauma?
Yes, sir.
In your negative history? You did mention.
Yes,
okay. Yeah, that's fine. No, I missed it. So Sudeep Kanungo says that yes, simple liver cyst, agreed. We can keep a possibility of a simple liver cyst, but again, a very large cyst which is palpable is probably, I don't know whether I have the evidence that whether hydrated will be more common or a simple. Vinay, what do you think? The large palpable cyst, you think more likely to be simple cyst or a hydrated cyst?
So simple cyst, the recurrence rate are quite high rather than hydrated cyst.
But there is a history that it has been gradually, progressively increasing in size.
Irrespective of the clinical history, it is more common.
But palpable simple cyst.
It's quite uncommon that simple cyst used to grow in such a large size that it is going to be common.
So that is why I thought hydrated, but yes, there is nothing against saying that it could be a simple cyst also. Yeah. Okay, let's proceed.
Coming to general physical examination, sir. My patient is a 68-year-old female, averagely built and nourished, with a BMI of 22.3, ECOG status of 1.
Sorry to interrupt.
Yes, sir.
On examination, how can you say that she's 68-year-old? You can't. 68-year-old is history. Here you should say elderly lady.
Okay, sir.
There is a difference. Yes, please carry on.
Elderly female, averagely built and nourished, with a BMI of 22.3, with ECOG of 1. Patient is conscious, cooperative, well oriented to time, place, and person. Pulse rate of 68 beats per minute, blood pressure of 106 by 80 millimeter of mercury, respiratory rate of 18 per minute, and saturation of 99 to 100% at room air. Patient is afebrile. At the time of examination, there is no pallor, icterus, left supraclavicular lymphadenopathy, or pedal edema. Coming to examination of the abdomen, inspection-wise, there is a...
Suppose this patient, while she is waiting for you to be examined, is persistently coughing.
Yes, sir.
And she is even spitting out in a piece of cloth or in a spittoon. This particular patient.
Yes, sir. I would think of ruptured hydatid into the pleural cavity, which can present with cough, and I expect
any other possibility? One is rupture of the hydatid, and second, you did mention hydatid at multiple sites.
Yes, sir.
So it could be hydatid in the lung.
Lungs, yes,
isn't
sir.
It? Hydatid in the
yes,
lung,
sir.
which is irritating the bronchus and causing persistent dry cough. So in a patient with hydatid of the abdomen, liver, or any other place, at every stage you have to be conscious of hydatid cyst in the liver or a rupture. Why is the hydatid of the lung is important? I would have asked that question later, but since we have raised the issue now, why is it important to know that there is hydatid or no hydatid in the lung?
One, sir, it can have
very important.
compromised lung, where respiratory efforts are not good, or else
that would be obvious.
If we are
most important is when you give positive pressure ventilation and
yes,
you did not detect or suspect the lung. Yes, Sudeep is right that in the lung there is no pericyst. So when you give positive pressure ventilation, the cyst can rupture. That is why when you are dealing with hydatid anywhere else and the lung, you have to handle the lung first. Yes. And then go to the other organ. Yeah, please carry on.
Coming to inspection, there is a solitary...
Go back. Sorry, go back.
Yes.
Why did you specifically look for left supraclavicular lymphadenopathy? Your differential diagnosis did not include a malignancy.
Yes, sir. Yes, sir.
Although going back, I thought that somewhere in low down, maybe in the list, probably we could keep the possibility of a slow growing malignant lesion, which has grown progressively over 1 year, but not given rise to any other symptoms. I'm not sure whether a slow growing HCC can have a 1 year course without treatment.
Yes, sir.
Okay.
Yeah, it should have been generalized lymphadenopathy rather than left supraclavicular.
Yeah, if you are thinking of a benign
of malignancy as of now.
Yes.
Shall I continue?
Yes, please.
There is a solitary oval mass of 7 into 8 centimeter in the epigastrium extending into the right hypochondrium. The surface appears smooth, all borders except upper border well made out. The lump moves with respiration. There is no cough impulse. Skin over the swelling appears normal. The umbilicus.
According to geometry, 7 into 8 centimeter is not oval. It is spherical, rounded. Oval means one axis is much longer than the other.
Yes. Okay.
Yes.
The umbilicus is pushed downwards, inverted. There are no scars, sinuses, or visible pulsation or peristalsis seen. No renal angle fullness. Hernial orifices appear normal. External genitalia is normal. Coming to palpation, abdomen is soft and there is no local rise of temperature. A solitary oval-shaped mass of 10 into 8 centimeter is seen in the epigastrium extending into the right hypochondrium. Mass extends 10 centimeter vertically from right costal margin downwards and from midline to 8 centimeter to the right of midline. Borders are rounded. All borders except the upper border is well made out. Fingers cannot be insinuated between mass and right costal margin. The surface is smooth. Mass is non-tender to palpate, firm in consistency. It moves with respiration. No intrinsic mobility. Plane of the swelling is intra-abdominal and intraperitoneal, and skin of the swelling is normal. No other mass or organ palpable. Renal angle is normal. Hernial orifice normal, and external genitalia is normal. Coming to percussion, liver dullness starts at 5th intercostal space. Liver span is 12 centimeter in mid-clavicular line. Dull note of the mass is continuous with the liver dullness, and there is no flank dullness present. The rest of the abdomen is resonant to percuss. Auscultation-wise, normal bowel sounds are heard. No bruit heard over the mass, and per rectal examination is essentially normal, sir.
Can you go back to palpation? Did you describe whether there is pulsatility in the mass, epigastric mass, elderly patient? What other possibility?
Aortic aneurysm we should keep in mind.
Not common in our patients, but that's another possibility. So, since you did mention no bruit, you should also have mentioned that there are no pulsations, whether intrinsic or transmitted in the lung.
Yes. Okay.
Yeah.
And rest of the systemic examination is essentially normal. Coming to the summary, 68-year-old female with no comorbidities, with gradually progressing mass in right upper quadrant since 1 year, with recent development of mild dull aching intermittent type of pain since 15 days. No associated fever, jaundice, loss of weight or loss of appetite. On examination, there is a firm, non-tender epigastric mass with rounded and well-defined borders, except the superior border. It moves with respiration without intrinsic mobility. Dull note of the mass is continuous with liver dullness without any pulsation or bruit over the mass.
So, Krishna,
Yes.
so what will be your probable diagnosis after this summary?
I'll keep benign.
Or you have the confirmed diagnosis?
No, sir. Even now, I have differential diagnosis.
Okay.
Most probably, it is a benign epigastric lump, sir. My differential diagnosis still remains hydatid cyst of the liver. I want to keep simple hepatic cyst as one of the DDs here. And hemangioma of the liver, I still want to rule that out. And pseudocyst of pancreas, sir, again.
Why pseudocyst of pancreas?
Epigastric lump, I just want to rule out, sir, largely asymptomatic, even though there are no inciting features.
Okay. Here these differential diagnosis.
Same as earlier. Okay.
I have.
So as I think Sudipto pointed out, simple cyst also probably, whenever we think of hydatid clinically, we have to keep the possibility of simple cyst also, because the history and findings would be more or less the same, isn't it?
Yes, sir.
Yeah. Okay.
Retroperitoneal tumor.
So your first two diagnoses are cyst, but you said it is a firm lump.
Yes,
Are
sir.
cysts firm?
Abdominal examination, abdominal wise, soft cystic swellings appear firm in examination.
Mm-hmm.
Abdominal
So anywhere else, cysts cannot be
tensely
firm?
cystic swellings can appear as firm.
Yeah. The answer is that a tense cyst will always feel firm. It will not be soft.
Yes.
And what is the other finding which confirms that it is a cyst? One is the consistency.
And the rounded borders.
Yeah, fluctuation. See,
Okay.
the two typical what is the commonest cyst in the body which we get in the exam, in general surgery exam? Cystic lesion.
Sebaceous cyst and
and hydrocele.
Hydrocele, yes, sir.
So typical are soft and fluctuant. But
yes.
if the cyst is tense, then it will feel firm and you will not be, or you may not be able to elicit fluctuation, which anyway in the abdomen is difficult to elicit. Okay. So again, I think it may not be inappropriate that in an elderly lady who has a palpable lump in the upper abdomen, although the findings are more suggestive of a benign disease, but at least in history, I thought that somewhere low down in the list, we could say we would like to exclude a slow growing malignancy also, or a slow growing neoplasm also.
Yes.
Okay. But yeah, I agree that after the clinical examination, probably it's unlikely.
Yes,
It looks like a cyst, smooth, well-defined, rounded lump, which is largely asymptomatic. Okay. So what will you do?
I'll do 2 sets of examinations, sir, just to come for a diagnosis, and next for the evaluation.
Just a minute. Sudipto says that can it be liver metastasis due to NET in the left lobe of liver? What do you say to that?
Yes, sir. Liver metastasis can present as a cystic swelling, but patient will have other signs of the malignancies like loss of weight or appetite or anorexia.
That is why he has specifically asked neuroendocrine tumor. He has not said adenocarcinoma. See, neuroendocrine metastases are different from adenocarcinoma in various ways. One is that the primary tumor can be very small, but the metastasis can be multiple and big. And usually these patients do not have the systemic features of malignancy, like, as you said. In fact, if you see a relatively young patient and you see multiple liver metastases and patient looks reasonably all right with no systemic symptoms like anorexia and weight loss, you should immediately start thinking of neoplasm like neuroendocrine tumor, like GIST. These neoplasms do not cause anorexia and weight loss even when metastases are present. But I would say that, yeah, Dr. Kotecha also says the same thing, that GIST also is a possibility. So these are slow growing neoplasms which can even metastasize without causing any systemic problems. So, but to make a clinical diagnosis of a neuroendocrine tumor with liver metastasis would probably be a little difficult. And when we say that neuroendocrine metastasis can be cystic, or neuroendocrine tumors themselves can be cystic, it is on imaging. Clinically, they don't appear to be cystic, like in this case, firm, smooth, well-defined lump. So theoretically, it is possible, but clinically, it probably would be very difficult to justify that diagnosis.
May I interrupt, sir?
Ajin, yes.
Yeah, you should consider a biliary cystadenoma, though jaundice associated is seen in 20 to 30%, but the remaining ones can still be a biliary cystadenoma. It will have all the features of a hereditary cyst or a simple cyst of the liver, but it is more notorious to transform into malignancy. I agree with Sudipto and all that it could be a GIST or it could be a hemangioendothelioma, which is large and slow growing. In low grade hemangioendothelioma, you can get this kind of a presentation, especially where you have not been able to demonstrate fluctuation or it's not soft and cystic. Second thing is, if you are going to palpate the liver, even with a hydrated cyst, you may not get features of the cyst if it is deeply paced. If there is overlying liver parenchyma, you won't get any of the features.
Yes.
So these are all possibilities which you have to keep in mind, and maybe when the discussion goes further, you can mention them. But clinical diagnosis will have to be of the common conditions only. But as we all know, that what looks like a hydrated finally can turn out to be a simple cyst or vice versa. And many patients now with more and better imaging, we know that biliary cyst adenoma can look like a multiloculated hydrated cyst with daughter cysts. So these possibilities have to be kept in mind. Yeah. So what will you do? She comes to you in the OPD.
Next, I'll get an ultrasound of abdomen done, sir, for the patient. And
Let's see.
Ultrasound abdomen shows liver shows multiple cystic lesions seen in both lobes of the liver. The largest measuring 10 into 8 centimeter with normal liver echo texture. It also shows that gallbladder is distended with multiple stones, with the largest stone measuring 9 mm. Sorry, wall thickness is normal, CBD normal in caliber, pancreas is normal in size and shape, and bilateral renal cortical cysts are seen, largest measuring 3 into 2 centimeter. No significant lymphadenopathy, no free fluid.
So what do you think?
Depending on the ultrasound finding, I'll be thinking more in terms of liver cyst rather than hydrated cyst, sir, as of now.
Hydrated also is a liver cyst.
I mean,
Think
simple
of
cyst.
polycystic disease of the liver and kidney.
Yes, sir.
See,
Yeah, and if I'm not mistaken, it's the autosomal dominant type which presents with this kind of a presentation,
Yes,
where you have liver cysts, renal cysts, and pancreatic cysts.
yes, sir.
so there are multiple cysts in both lobes of liver, and there are cysts in both kidneys, and they are large. Three centimeter is a large. Small
Yes.
cysts are. So most likely diagnosis here now becomes a polycystic disease of the liver and kidney. What is missing in the ultrasound report?
They have not mentioned about the wall. The wall.
Surgical meeting, no?
Nature of the cyst they have not properly mentioned, sir.
What do you mean by nature of the cyst?
How is the cyst wall? Whether there are any septations and any solid component.
Any daughter cysts, your first diagnosis of hydrated disease, isn't it?
Yes,
So
sir.
whenever a cystic lesion is seen on ultrasound in any organ, the sonologist should mention, yeah, Sudeep has rightly said, daughter cyst, laminated membrane, debris, all these can be very well seen. Ultrasound is a very good investigation for the diagnosis of hydrated disease because it can see the membranes, it can see daughter cysts, it can even see hydrated sand, which appears as ecogenic material inside the anechoic cyst. So all those, and as you rightly said, wall, whether it is regular, irregular, same thickness all around, or irregular thickness, are there any solid components? So all these things should have been mentioned in the ultrasound report, which would further help you to decide as to what the cyst is. But based on whatever information is available, it looks like polycystic disease of the liver and kidney.
Yes.
Also, another
yeah,
thing they have
Sudeep.
not mentioned the wall thickness. That
Yes.
is important because it could be a neuroendocrine metastasis with cystic metastasis, or it could be what you call alveolar echinococcosis. I'm hearing that in Northwest India nowadays they are seeing alveolar echinococcosis. I might be wrong about that.
And Sudipto has said that since there are multiple cysts, large cysts, the exact location in relation to hilum is not mentioned, whether it is causing any biliary obstruction and IHBRD, and plus rest of the abdomen. spleen is not mentioned, the peritoneal cavity is not mentioned. If it is hydrated, there is a possibility that there may have been a rupture at some stage and there are intraperitoneal cysts. Okay.
Yes, sir. Yes, sir.
So whenever you are given a report, you not only have to describe and analyze it, you also have to point out what is missing in that report and what else information you would have wanted.
Okay.
Yeah. Next.
Next, I'll go ahead with CT scan to better characterize the lesion and to look for the
What do you
things.
mean by better? What do you mean by better characterize? What else do you want?
To know the wall status of the lesion and any solid components or any septations, or to know the association with hilum and adjacent structures.
Is there any doubt in the diagnosis?
No, sir. As of now, it's looking more of a polycystic liver disease, but
How would CT change your plan of management?
yes, sir. Patient is having pain. One thing, recent development of pain. If we are planning for any surgical intervention, I want to see the relationship of the cyst with the adjacent structures and hilum. And
if it is polycystic disease of the liver and this patient is having pain, would you think of a surgical intervention?
a large cyst can be, because in examination there is a large cystic lesion, sir. So it can.
Then ultrasound confirms that there is a 10 by 8 centimeter cyst.
Yes,
but
sir.
is her pain? You said she doesn't even require analgesics or
Yes.
occasional analgesics. So is her pain severe enough to think of a surgical intervention in polycystic disease of the liver with bilateral renal cortical cysts in a 68-year-old female?
As of no, sir. But patient is also having cholelithiasis. So
Asymptomatic.
Multiple stones.
You did describe any biliary pain, isn't it?
Yes, sir. And
so these are asymptomatic stones in a 68-year-old lady.
Yes, sir.
That is a separate topic in itself, which if time permits, we will discuss, but let us confine our discussion. So if we are sure that this is polycystic disease of the liver, what
Yes,
I'm
sir.
asking, based on her history, do you think that she requires any surgical intervention or any intervention?
No, sir. As of now, no.
I don't think. Unless the pain is severe, it is incapacitating, interfering with quality of life, that probably would be the only indication. So a more important reason for CT here would be to confirm that it is only polycystic disease and it is not something else which requires surgical intervention. For example, hydrated, for example, a biliary cyst adenoma. What else? No, I think that's all. So that could be the only reason, isn't it?
Yes, sir. Yes, sir.
Not
When
that
would we
whether
do-
you would.
Excuse me, sir, please go on.
Yeah, Rajat.
Yeah, when would you consider a patient of adult polycystic kidney disease and liver disease for transplantation? What parameters will you look for in your biochemistry to suggest that that person needs transplantation of some kind or the other?
When there are deranged LFTs.
No, what about the blood pressure? What is the importance of blood pressure in this disease?
Polycystic kidney disease can have hypertension.
What else can they have? In the brain?
And the aneurysm, they can have very aneurysm.
Yeah, what is that condition called?
Very aneurysm.
No, it's called von Hippel-Lindau syndrome.
VH. Okay.
Yeah. So transplantation is if there is renal failure associated with significant dysfunction in the liver parameters, then you can do a bilateral nephrectomy, you can do a liver transplantation, and you can do a what you call kidney transplant. Why you need to do it in liver is only when there is evidence of portal hypertension, which if you leave without intervention can occur because of compression by the cyst. And as the cysts grow, they will progressively destroy the liver parenchyma until they start compressing the portal venous system and they cause portal hypertension.
Okay.
Okay, so we give you that you want to do a CT to better characterize it. So did we do a CT?
Yes, sir. We did.
Anything before doing the CT scan?
I will do hydrated serology, sir. As I was thinking of that, I'll rule out it first.
Anything specific to CT scan?
RFT will get it done, sir, to know the.
Yeah, very.
It
As
is
it is, before you do any CT scan, contrast enhance, it is important. But here we are thinking of bilateral cysts in the kidney. They are fairly large, 3 by 2 centimeter. So very, very important that you make sure that the renal functions are absolutely normal before you go ahead and do a contrast enhanced CT scan. So everywhere it is important, but here it is even more important.
Yes.
And hydrated serology, you mentioned. What is the role of hydrated serology in the diagnosis of hydrated cyst?
It is only complementary to the findings, sir. Clinical and radiological investigation. It acts as a complementary.
If it is negative, does it rule out hydrated cyst?
No, sir. Negative serology does not rule out hydrated cyst.
False negatives are known.
Yes, sir. Yes, sir.
Okay, so if you have typical radiological features, I mean, for all practical purposes, hydrated serology is not of much use, because if you have any doubt of hydrated disease and you have decided to operate upon the patient, most people would give the anthelmintic treatment at least for 1 or 2 weeks as recommended by WHO, and some people say even 4 to 6 weeks. Whether the serology is positive or negative, you can't say that serology is negative, so I would not consider hydrated at all. So that is why its practical use is very, very limited.
Yes.
Yes, let's see the CT. And as Dr. Desai said, that in polycystic disease, whether of kidney or liver, it is not the number of cysts, size of cyst, or how much of the parenchyma is replaced by cyst. It is basically the functional status, whether there is liver dysfunction and whether there is CKD. That is what indicates intervention, especially transplant. Pain, you may, if there is a large cyst, you may think in terms of marsupializing it to relieve the pain.
Yes. Sir, I'm not able to see that. Yes, sir.
Yes, we can see.
Okay.
Play the video.
Yes. I'll show the arterial phase first, sir. Sorry, I'll show the plane phase first. This is a plane phase of contrast and CT of the abdomen, axial cuts. Here we can see a hypodense, multiple hypodense lesions in the liver. Liver border is rounded, and vasculobiliary markings are not prominent. and a few calcifications are seen in the aorta. Coming down, large cyst can be seen, which is well described in the other phases. And here we can see stones in the gallbladder also with a distended GB. And there is no free fluid in the abdomen. And rest of the things is better visualized in other phases.
So a large cyst in the left lobe of liver, which has a major extra hepatic component. It is
Yes.
hanging in the peritoneal cavity, and
Yes.
stones also, although doesn't matter here, but large calcified gallstones. Yes.
It doesn't show any evidence of hemorrhage. So what is the cause of pain? Is it stretching of the Glissen's capsule?
Yes, sir. One of the reason can be stretching of the Glissen's capsule because it is a huge cyst which is extending into the cavity, peritoneal cavity also.
How do you not say this is Caroli's disease of the liver? Because this kind of cystic dilatations are well known in Caroli's disease of the liver.
LFT is essentially normal, sir, without
even in
Actually, these are large cysts of varying sizes, whereas in Caroli's disease, you will see dilatation of the intrahepatic duct. So it is both may appear cystic, but these are large cysts of varying sizes in both lobes of liver. So that is why we are saying it is a polycystic disease.
In this is the arterial phase. There is no wall enhancement as such, and the wall is very thin. Coming to the arteries, celiac trunk and hepatic arteries, the left hepatic artery just traverses over the posterior surface of the cystic lesion. That's all. There is, as such, no other extra findings from that. And
what is fenestration operation?
Sorry, sir.
What is fenestration?
Fenestration is de-roofing of the cyst with evacuation of the contents, and de-roofing of the cyst is called cystic fenestration.
Is this case suitable for that or unsuitable for that?
Sir, yes, sir. This case is suitable for that.
Why?
Because it's a very thin wall, sir, and it is extending into the abdominal cavity with a very thin wall, superficial lesion over the second and
if the patient is asymptomatic and is manageable by painkillers, there is no evidence of portal hypertension. Liver, there is only one cortical cyst.
Yes, sir.
Can it not be age-related cortical cyst with multiple cystic disease of the liver? And only if the patient is symptomatic, you should do the fenestration operation.
Yes, sir.
Yeah. So no symptoms, no need.
Yes, sir.
So actually a cyst like this, where most of the wall of the cyst is not covered by the liver parenchyma, you can excise a major part, more than half of the circumference, and it becomes like a marsupialization, that the remaining cyst, which is covered by liver parenchyma, is less than what you have removed. So the whole cyst now is open into the peritoneal cavity. So, but as Dr. Desai said, that the only indication for any intervention in a pure cystic disease of the liver is symptoms or complications.
Okay, sir.
And Sudeep has said that some central dot sign in MRI. In which condition, Sudeep? Can you come in?
It's seen in Caroli's disease.
So what is that central dot because of?
Because of the adjacent portal vein
Mhm.
branches.
Okay. I was not aware. Fine. Yeah. Yes. Anything else on the CT in other phases, or is it the same?
No, sir, it's the same, sir. Even in
Okay. So any other investigation you want?
uh, blood in LFT and RFTs, I want to see whether it
Yeah,
is.
that you
Yes,
said they are normal.
yes, sir, it is normal.
So at some stage we thought of a neuroendocrine tumor. You want to look at the serum chromogranin?
Looking at this picture, it is very unlikely, sir, because associated renal cysts are also there.
Yeah, so these are all pure cysts with no wall thickening, no solid component. As we discussed, NETs can look like cystic, but that is because of cystic degeneration. So they don't look like pure cysts, they look like cystic masses. Here, these are pure cysts. So that is why NET is almost unlikely. So you're right that you are not now considering a neuroendocrine tumor, isn't it?
Yes, sir.
Would you like to get AFP done? Alpha fetoprotein?
No, sir.
Yeah, again, the radiological picture is not of any kind of or any variant of HCC. These are pure cystic lesions with no solid component. So you don't need to do any tumor markers also. Okay.
Yes, sir.
Any other investigation you want?
I think a CA19 and a CA would be a sensible thing to do because we really cannot rule out biliary cystadenoma. They are notorious mimics of benign disease, and with just one large cyst in the kidney, labeling it as polycystic kidney and liver disease would not be appropriate. Mostly by the age of 68, they usually have enlarged kidneys with multiple cysts in both kidneys, and the kidney size increases.
Yes.
Yeah,
This
so
is more
that's what
of
Sudip thought. He would have liked to have an MR imaging. And
Liver
as I
disease.
earlier also, in general, if you are evaluating a cystic lesion seen on ultrasound, most people, most radiologists actually would prefer an MR rather than CT because MR is better for evaluation of cystic lesions, whether it is in the liver, whether it is cystic neoplasm of the pancreas. So maybe instead of CT scan, an MR may have been a better choice of the next investigation, which would settle all these issues because it will probably be better to see any laminated membranes, any daughter cysts, any features of biliary cystadenoma. So, was an MR done in this case?
no, sir. We have not got it done.
Yeah, but I think
Better.
Colidoco. Why are you, Sudeep? Why are you thinking of colidocolithiasis? Yeah, come in.
So there
Yeah,
was a
but that pain.
pain in the main.
Yeah, but that pain is not even biliary colic. It's a very mild, dull, diffuse. As Krishna said, it's more like a discomfort. So most probably that is the pain of the stretch of the liver capsule. I don't think you could have said that because there are gallstones, I would like to rule out associated colidocolithiasis. That is okay, but that is not our primary concern at this stage. That is an incident that probably would be an incidental finding. LFT normal, no IHBRD seen on ultrasound. So I don't think that would be the
Even if
reason to
you are
do the
planning
MR.
for a sir operation for this patient, is there maybe a fenestration also? So
Yes.
cholecystectomy can be added, I think, in this patient, or is it?
Yeah. So if you are going in for
That's
the
why.
cyst, yeah, then you can add. But then what I'm saying that MR you would not do to look for CBD stones. You can say that MR will tell you about CBD stones also as an additional, as a bonus finding, but that is not the indication. There's no indication to do MR for CBD stone in this patient. She has no
Yes.
history of jaundice. She has no history of pancreatitis. LFT is normal. There's no IHBRD. So she falls in the low risk for CBD stone, which is not an indication. And we don't do a routine MR before every cholecystectomy. There are only few Japanese centers and surgeons which do an MR as a routine before cholecystectomy, but the reason is not CBD stone. The reason is to delineate the biliary anatomy. But that is not the recommended or accepted protocol.
Yes.
Okay, so Krishna,
Yes.
you've done with your investigations.
Yes, sir.
So what will you advise her, this lady?
I'll advise monitoring of the patient with close follow-up. I mean, if pain increases in intensity or if it becomes unbearable, if the analgesic use becomes more, then we go ahead with fenestration of the large large cyst which is present. So I'll keep her in a follow-up.
So fenestration, how?
A laparoscopic, sir.
All cysts?
No, sir. Only the largest cyst which we are seeing, which is protruding into the.
But
Right.
go up and down on the CT in this phase only. There are some other cysts which are on the surface.
Yes, sir.
What about them?
These cysts I'll not tackle, sir, because there
What
are
about the
multiple.
renal?
Sorry, sir.
I don't agree with him, sir. Every
Whatever
visible
is, yeah.
surface cyst has to be fenestrated.
If you are going in, whatever is seen on the surface, you would like to fenestrate or marsupialize them. Uh, so wherever there is a thin wall of the cyst, of course, there is always a thin parenchyma covering it. The pericyst, like in hide, it everywhere will be there, but it is thin. So I would say that whatever is laparoscopically seen and wherever there is only thin wall of the cyst or thin pericyst, I would probably like to. Now, this one, the one which you are seeing in the right lobe, is all in the parenchyma, inside. That
Yes.
I won't touch. That I won't even put in a needle. But the whatever is seen on the surface, if you are going in, then probably I would like to tackle them. So indication
One,
for intervention is
one
only
question.
symptoms. Yes.
Will it not increase the secretion, sir, if cyst number is more and we are just deroofing large number of cysts?
Mm-hmm.
The secretions
So,
from the cyst can increase and collection in the peritoneal cavity. Will it not occur?
No, nothing
no,
like that occurs.
no. Marsupialization is of simple cysts is a accepted treatment. Whatever secretions are there, peritoneum is a good absorptive surface area. It will absorb everything. There will be nothing collecting in the peritoneal cavity. So much of acetic fluid is produced and absorbed by the peritoneal cavity.
Okay.
So that is not the fear.
Okay.
So whatever is seen on surface, if you are going in, I'm not saying that presence of cysts is the indication. Presence of pain is the indication. And if you are going in, then you would like to deal with whatever is seen and whatever can easily be done.
Okay.
Anything else? Any other student
Sir.
or faculty would like to say or ask anything? Yes. Oh yes, yeah, very important. I thought of it at an earlier stage, but I forgot. This is very, very important. Very, very important. In all familial diseases, if you don't advise a family screening, it can be considered as negligence. So a patient with FAP, if you don't advise screening, patient with polycystic disease, if you don't advise screening, patient with strong family history of breast cancer, I mean, for general surgical students. So you have to keep that in mind, and then you have to advise screening of all first and second degree relatives, because this is an autosomal dominant transmission. So very high chance that some members of the family will also be found to have polycystic disease. That's very important. Yes, Kulbhushan. Kulbhushan, you want to say something? Vinay, anything want to add? So shall we then close? Krishna, any
Yes,
other question in your mind?
Sir, can I ask a question, sir? Where would you like to do a cystic aspiration, sir?
Cyst
Which patient?
aspiration, yeah, cyst aspiration seems to be a simple procedure, ultrasound guided, but invariably the cyst will refill in a short period of time. So I don't think cyst aspiration for as a treatment. If you have a diagnostic dilemma and you want to examine the cyst fluid, that may be justified, but not as a therapeutic intervention.
And if this patient would have been an acute abdomen with like a features of infection, so would that be in a drainage also can be a
So
compulsionary?
that is a different scenario. Infected cyst, whether it is an infected simple cyst or an infected hydrated cyst, becomes a liver abscess. Then it has to be treated like a liver abscess, which means a image-guided percutaneous drainage and antibiotics. So that is like a liver abscess.
Okay, sir.
But
Thank you.
here, history, examination, and the investigation findings, although we didn't look at them, but I presume they are normal, do not suggest that there is any suspicion of infection.
चार नंबर नहीं मिलेगा अपने
So can we close?
Yes.
We are already 7 minutes past. Okay. Thank you, Krishna. Thank you. Good,
Thank
good
you, sir.
presentation. Very
Thank you.
much. Yeah. Thank you, Rajan. Thank you.
Thank you, sir.